Thanks, Kevin. I'm sure many of you will be expecting to see Diane Murray tonight, but unfortunately she's unwell, and that's why I'm here. You were cheating. What I'm going to do is just give you hopefully a brief summary of the sepsis work within Ayrshire and Arran since we became involved with the Scottish Patient Safety Programme. So I've also got the story so far, the same as Kevin's slide, but I don't have the lovely picture that you had on it. Maybe the next time. It was flung together very quickly. So as part of the first phase of the programme, in order to meet the cardiac arrest reduction, what we did in Cross House and Ayr was introduce the emergency response team. They didn't just respond to people who were deteriorating. They trawled the ward looking for people that perhaps were becoming more unwell to try and intervene before they got to that critical stage. Then following on from that with the Sepsis VT Collaborative in 2012, we got together a working group and thought, how can we build on this a bit more to try and improve sepsis care within Ayrshire and Arran? What we came up with was a dual response. Dual response within Ayrshire and Arran is made up of a member of the emergency response team or a hospital at night ANP practitioner out of hours, and that can be with another, so it can be with a medical practitioner, a clinical support worker or another ANP. And what the dual response was, anyone who was scoring a Muse of 4 or above, that they should have initiated 2 people to come so that if they were septic, then they could intervene and give the necessary treatment within the hour. Also leading on from that, earlier this year we were actually identified as an outliner in HSMR at Ayr. So again we thought, how can we put the work that we've already put into place and sort of tackle this head on? So what we came up with is a deteriorating patients breakthrough series collaborative, and that's incorporated the sepsis work up until now. What we thought we would do is, from past experience in the work that we've done in the patient safety programme, some things have taken quite a lot of time. For instance, when we did Back to Basics, which looked at Muse compliance, SBAR safety brief, it took us 2 years for one hospital. So the reason we decided to go with the breakthrough collaborative was to try and get the pace and scale of spread within the clinical areas. As part of that, what we thought we would do was reinvigorate the dual response to the Muse, because there was that feeling there that there was still people being missed. ERT, hospital at night weren't being called when patients were scoring a Muse of 4 or above. So in March of this year, we had a test site, which was Station 14 at Ayr, and it was actually a 3-pronged approach. We had clinical improvement staff going in and working with the nurses in the area about Muse, how to identify and recognise patients, about escalation to appropriate either ANP, medical staff. The ANPs also worked very closely with the medical staff and nurses, gave education on sepsis physiology, sepsis 6, and just to kind of reinforce the care of it. Again, after a few months, July of this year, we decided as part of the collaborative we'd add on another 3 wards. So at the moment we've got 4 wards that are working on that at the moment. So within the adult acute sepsis group, what you're looking for to identify that a patient is suspected of having sepsis is that they have 2 or more of the following SIRS criteria, plus a suspected infection or known infection. As Kevin said earlier, you can have SIRS for a reason that's not infection, and some other conditions, blood transfusion, pancreatitis and burns can cause a SIRS response, so that's why it should be plus a suspected or known infection. The Sepsis 6 bundle for the adult acute, again delivered within the hour, and the 6 components are high flow oxygen, blood cultures, IV antibiotics, measure serum lactate, IV fluid resuscitation and accurate urine output measurement, and that's something that we also know as well that we need to have some improvement work on. This was a local audit that the ANPs did because they were sure that when there was a dual response that it did improve the compliance with the Sepsis 6 bundle. Again, it was an all or nothing. They carried out an audit from July of last year to April this year, and the dark blue at the bottom shows the compliance with the Sepsis 6 bundle when ERT or ANP is not involved. And you can see from the lighter blue at the top, compliance is much better when there is the dual response there. They did that, that's for Cross House Hospital. They also did it for Ayr Hospital. And again, no surprises there, it just gives the same sort of picture. So we know there is evidence there, if you have that dual response, that compliance with the bundle will be improved. This is from this year, March of this year to July this year. When ANPs are called to see a patient with a Mews of 4 or above, they complete a sepsis form. So with all the education taking place, they thought they would do an audit to see the numbers of forms they were getting back. Again, you can see from that last year, which is a lighter blue colour, there was much fewer forms coming through. So hopefully that education and awareness is starting to make a difference. So one of the things that they did when they started with Station 14, was carried out a survey of nursing staff, medical staff, to find out what was the reason that they weren't initiating a dual response call. So these are some of the reasons. It became clear that some people weren't even sure who they call, when they call. It depended on what activity was going on in the ward, and sometimes it was already being managed by the medical staff that was there. So what they did is they looked at the deterrents that were identified from the questionnaire and developed a flowchart, which I'll show you just in a second, so that it provided guidance clear and accurate as to what steps you should take in order to get the dual response initiated. They got engagement with the medical staff by involving them right from the start. They did a lot of face-to-face teaching, both medical staff and nursing staff, and there was a series of lectures as well carried out, because some of the times when they were going into the ward, it was really difficult to actually be able to pull the staff off due to the workload of the day. So there's been quite a few lectures been set up as well. This is a flowchart specifically for Ayr, so it's quite clear, concise, lets people know what to do when a person scores 4 or above and needs to have the dual response. This is the driver diagram from the second phase of the patient safety programme for sepsis. As you can see, the primary drivers are all about recognition, care delivery and education and awareness. So what we did as part of our Breakthrough Collaborative is build our own. This is what our aim is: true improvement methodology, how much by when. So by December 2015, we want to show that 95% of people with a physiological deterioration will have a structured response and plan in place. Again, our primary drivers are quite similar. It's all about identification and escalation of not just a septic patient, but the patient that's deteriorating, and education. So a few slides here just showing some of the data. I have to apologise, it is only in relation to specialty. As this was sort of last minute, I wasn't able to get any information on ED, but I can confirm there has been a lot of work done there. Kevin, you talked about process mapping. They've done a great deal of work in that, bringing porters in to try and look at the journey and how they can improve it in order to meet the time zero for the Sepsis 6. So I do apologise, there's no graphs for that. So the first 4 slides are our test sites for the collaborative. So this is Station 14. Which was the first one, who started in March. As you will see at the end there, they do have a shift going on. Did drop the second last month, but hopefully, you know, with the work that'll keep continuing to improve. One of the annotations shows a CLAPS meeting. What that stands for is clinician-led acute patient safety. And that was the ward sister from Station 16 that actually decided to implement that. And they have a discussion every day. I think it's 11 o'clock or 2 o'clock they have, but a lot of the wards have now introduced it and they've all got different times. And what they discuss is any patient that's given cause for concern. So they're preempting, and that's now actually spread naturally within the majority of wards at Ayr now. So that's really been very positive. Station 9, excellent compliance there. Obviously there's quite a lot to learn, there's something good happening there, and hopefully that's what we can share as part of the collaborative when we have a learning session. What we will be expecting these test wards to do is to share with the remainder of the wards the work that they've done and how they've improved sepsis care, so that that can then spread naturally, as I say, at a faster pace than what we've done in the past. Station 3, I have to say about this slide, the numbers in Station 3 are very, very small, sometimes 1 patient, 2 patients, so it can have quite a big drop in compliance. Station 7, again, patients who have the dual response, still work going on there, but it's early days. It's early days. This is just the overall picture for Ayr Hospital with compliance with the Sepsis 6 performed within 1 hour of time zero. Again, we're now looking at data weekly as opposed to monthly, so that you can actually identify what the issues are sooner rather than later and take steps to try and make that improvement. This is Cross House Hospital. Again, last few months there's been a shift there. Compliance is improving. Time to first antibiotic. Ayr Hospital, we're now sitting about 50, and Cross House is just sitting at 45, so just that slight bit better, but again, work's continuing. I must also say as well that with the antibiotic of choice, both sites are actually sustaining 100% compliance with antibiotic according to policy. Oh, that wasn't there earlier. It must be the men at the back that have done it. Antibiotics given within an hour of time zero. It's quite heartening to see when you showed us a national figure there, Kevin, so we're doing okay. So the next steps that we're looking to do in relation to sepsis for the acute adult, we're going to continue with the spread at Ayr, and what we want to do in the coming months is mirror that improvement activity in relation to sepsis, dual response, raising awareness in Cross House. As I said, we're going to have our formalised lecture days or local learning sessions, if you like, for all the sharing of the good work that's going on. Our ANP team are developing a Sepsis Learn Pro, which hopefully, I don't know, Ruth, can you tell me when it will be available? No, but there's work going on in there anyway. And one of the things that's definitely been identified that we need further work in is fluid balance charting. It's certainly a big one, particularly in relation to urine output. So a group has already been developed for that, and we're starting to see what we can do to improve that. I apologise if that was quite fast, but as I say, it was a last minute thing, so thank you very much. I'm sure Ruth will help with the questions at the end. So I'd now like to ask Linda Clerihew from NHS Tayside.